topic is the present future of hypertension in women today. I'm Yunhong Wang from Beijing Anzhen Hospital. This title is a little bit large, but I will focus on the sex differences in hypertension. So just like this slide is a little bit similar to the previous professor's topic. So why we pay more attention to women from the whole lifespan in women's life, from the childhood, early reproductive, late reproductive, and the menopause. Yeah, there is a lot of factors that will influence their blood pressure, such as the topic like the polycystic ovary syndrome and the pregnancy and also the menopause. And as we speak later, the health of the mother and their exposure to adverse stimuli can influence the fetal development, and that will cause far-reaching consequences that increase the risk of hypertension and cardiovascular disease later in their own life and their baby's life. So that's why. So there are a lot of factors that can cause the gender differences. So the genetic multidimensional associations between domains of sex and gender difference exist. There is a lot of interactions between many endogenous and exogenous factors, such as the genetic architecture, the gene expression, and the epigenetic modification. Although the GWAS has only recently analyzed the X chromosome, but they have already identified loci on it associated with a lot of disease, including the cardiovascular disease, the metabolic disease, lipid, and the cardiovascular disease, including blood pressure. So let's take an overview of the cardiovascular sex differences from a molecular to population level. Let's see from the small molecule protein, DNA, chromatin, chromosome, cell, tissue, organ, to the final, the organism and the population. We can see that the minor differences at a small scale can lead to the meaningful variations on both the organism and the population. So a lot of phenomena are interactive, such as sex hormones and some hormones and the nervous system. So I will first introduce the sex disparity of hypertension, the prevalence. This is the recently published guideline from AHA, the hypertension guideline. We can see that between 2017 to 2020, there's still a tendency that when the people is younger than 60 years old, the hypertension prevalence is higher in men than women. But after 6 years old, the prevalence of hypertension increased in women more obvious. The same data is occurs in China. Occurs in China Cardiovascular Health and Disease Report 2024, we can see that the prevalence of hypertension is higher in men than women, but the sex differences may be partly influenced by using the same BP thresholds for both sexes, despite the naturally lower BP in young females. So let's see the blood pressure trajectory in the between the genders. Let's see this graph. At age 7, the SBP is similar between the in both sexes, and then it rises slightly faster in female until age 12, and then slows. So before 13 to 18, there is a gap widens between the genders. The males have a 10 millimeter mercury higher SBP than females. So and then due to the gap lessens until to the 60 years old, the blood pressure increase much more in female than the males. And also there is the sex difference between the blood pressure elevation from baseline levels. We can see that there is a faster rate of increase in women than men for all BP measurements, particularly for the systolic BP and pulse pressure after 20 years old. This is from 4 community cohort studies. There we can see when compared to men, the women exhibited a steeper increase of BP measures and begins as early as 30 years old. So let's, in summary, the healthy young females have lower BP than males at a similar age, but experience a steeper increase in BP from the third decade. We should have a better understanding of the underlying mechanism of BP increase in midlife. Then we can have the targets to improve the prevention of hypertension in both sexes. So we can see just as we talked about during the puberty, reproductive years, and menopause, there are a lot of factors that will cause hypertension in women. So there are a lot of regulators of BP that can cause sex difference, such as the autonomic nervous system, the RAS, and the hormone mechanisms. So there is a picture shown here. We can see the X chromosome and the age plays a very important balance between the depressor pathway and the pressor pathways. So if for the men, because it has the XY chromosomes and young age compared to the young women, they have the testosterone increased much higher than estrogen. So they have the vasoconstriction, the pro-inflammatory response, and chronic cellular senescence. So they develop blood pressure early in life. But after the women, in the menopause phase, they have the equal estrogen and testosterone compared to the young woman. So let's see the estrogen associated with the lower blood pressure in premenopausal females. And the testosterone is a prohypertensive hormone. So that's why the women have the lower blood pressure than men when they are young. Besides blood pressure, they have different trajectory and different patterns. Some other cardiovascular risk complicates with hypertension between genders, like the obesity is more prevalent in females, and the visceral obesity is more prevalent in males. For the metabolic syndrome, the prevalence shifts. Is higher in males in younger population, but is only higher in females after menopause. And the same is the same for the type 2 diabetes, dyslipidemia, smoking, and OSAS. They are all more prevalent in males. But autoimmune disease disorders are more prevalent in women. And also the complicated such as CKD, albuminuria, and gout are different between the genders. So there are also other differences for the hypertension-mediated organ damage. The first HMOD is the hypertensive heart disease that including two aspects, the left atrial dilation and left ventricular hypertrophy. These both phenomenon are more prevalent in females than males. So for patients with hypertension, the females more likely develop left atrial dilation and left ventricular hypertrophy. And also another difference is the arterial dysfunction and related complications. Let's see the large artery stiffness. They will develop with age and hypertension, but the female genders will enhance the elastin fiber rupture and make the artery stiffness worse. And also the female genders will make the prevalence of LVH, HFpEF, atrial fibrillation, and acute myocardial infarction more prevalent in the female genders. And also all of both the hypertensions and all the function of the heart, they will transmit it to the macro circulation. So The menopause-related change, such as the increased activity of the RAS system, the decreased activity of nitric oxide, and the increased activity of the sympathetic nervous system, all of these factors will contribute to the postmenopausal change of the macro circulation, so increase the vascular resistance. So in summary, the hypertension-mediated organ damage like hypertensive heart disease, arterial dysfunction show sex-specific incidence. Let's take a view of the sex differences in the whole cardiovascular disease incidence. So we can see from this graph that the heart cardiovascular events is higher in men than in women. So what's the cause? Let's say this picture. So we can see there are a lot of factors influencing, such as the sex chromosomes, the sex hormones, lifestyles, environmental factors, and the regulatory system and molecules. And all of these factors will finally affect the organ function. So let's see for the women, the cardioprotective regulatory pathway dominate from the puberty to the menopause. After that, women shifts towards the pro-hypertensive pathways. But in men, they don't have the cardioprotective regular pathways. They develop higher blood pressure and early cardiovascular disease than women. However, let's say there is another part of the opposite aspects between the genders. In this study, we can see that in the sex-specific analysis, the increase in cardiovascular risk begins at the lower thresholds of SBP for women. Even in this range, that is SBP is between 100 and 109 millimeter mercury. However, if we see men, we can see this risk begins when the SBP is higher than 130. And we can see also the hazard ratio is almost the same. For women, even the blood pressure is lower, the hazard ratio is 1.25. And for men, the blood pressure should increase above 130, and the hazard ratio is 1.26. So that gave us a lot of implications. So women will develop cardiovascular more easily, even at very low blood pressure. The same is the phenomenon could also be seen in the individual cardiovascular disease, such as myocardial infarction, the heart failure, and also stroke. Let's see the association of hypertension between atrial fibrillation. For females, they have higher risk of atrial fibrillation for the incident atrial fibrillation. From this study, we can see that from the Tromso study, there is a stronger association of elevated SBP with the incident atrial fibrillation. Either the SBP is increased, decreased, or permanently high, or the HR is higher than men. And also for both the paroxysmal atrial fibrillation and permanent atrial fibrillation, the females have a strong association between the increased SBP and the prevalence of AF. But for men, only the paroxysmal is associated with the elevated SBP. Another association between hypertension is the aortic valve stenosis. They also have the gender differences. For example, for the men, even they have the significantly higher aortic valve calcification scores at baseline and a higher change of the AVC value than women, but they are related with dyslipidemia. In men, in women, the risk factor is more related to hypertension, so they have the sex differences. And also for stroke. For stroke, this data show that young women may be disproportionately at high risk of ischemic stroke, However, this stroke may not only result from the hypertension, but hypertension is an important factor for stroke. So there is still needs more study to show the relationship between stroke and hypertension. In summary, for the association of hypertension with CVD is like this. Female with hypertension more often develop atrial fibrillation and HFpEF, while males more often develop acute myocardial infarction and HFrEF. And the cardiovascular risk increases at a lower BP level in females than in males. So how should we treat them? The first is the lifestyles. First, let's see the sodium restriction. From this study, we can see that either in the control diet or the DASH diet, the low sodium restriction could lower blood pressure more significantly in females than males. However, for the exercise, the aerobic exercise reduce blood pressure less effectively in females. Let's see the data. The dynamic endurance training on resting BP is more obvious in females, both for the SBP and DBP. And also the sex difference exists in the side effects or adverse effects and efficacy of the pharmaceuticals for hypertensive patients. This is because the drug's absorption, elimination, pharmacodynamics, distribution, and metabolisms. Overall, the female generally report more adverse side effects from the antihypertensive drugs. For example, they are prone to hyponatremia, hypokalemia, and arrhythmia with diuretics. They more frequently develop edema with CCB, and cough is more common in females using ACEIs. For the males, they more likely experience gout with diuretics and sexual dysfunction with beta blockers. About the efficacy, different studies yield different results. Some studies show that between the genders, there are similar treatment effects. However, some other studies show that females show greater blood pressure response to beta blockers and CCB. In the ACEI and ARB, between the genders also have different results. For example, for the losartan group, the females have better reduction in the primary endpoint, and the benefit of ACEI treatment was only demonstrated in males in another study. And achieving a target diastolic BP lower than 18 millimeter mercury reduced the AMI only in women. So still we can see the sex difference with treatment effects. In summary, the sex differences in efficacy and adverse effects of antihypertensive drugs are well described. These differences should be better communicated to the healthcare providers. So let's see the hypertension awareness and control. Generally, the hypertension awareness is higher in females, but the blood pressure control is worse in females. From this Canadian study, we can see that between 2007 to 2017, the awareness, treatment, and control rate stays almost unchanged in men, but in women, the three risks deteriorate. So in summary, why do we pay more attention to women? There are a lot of facts are different between the genders, such as the blood pressure patterns and trajectories. There are complicated cardiovascular risk factors, the HMOD and the complicated cardiovascular diseases, and also there are response to the antihypertensive drugs. So the present there are a lot of factors that can cause the sex and gender disparities. For example, the increased risk factors and comorbidity burden in women, and also the delayed and suboptimal care for women experiencing cardiac events and the and misdiagnosis of cardiovascular disease in women, just as the previous professor said. in the future, maybe we can have some measures to take to narrow the gap. There are some in a lot of aspects, such as vendors, publishers, funding bodies, and even researchers and educators, to improve the frequency and accuracy of sex reporting, to isolate the sex as a biological variable from confounding genetic variability in several aspects and careers. So finally, there are still a lot of questions to be answered, such as the BP threshold for the hypertension between genders, and whether the current therapies for the treatment of hypertension and associated and organ damage equally effective in men and women, and the cardioprotection effects can be maintained even after postmenopausal women. And could this protection be extended to men? There are a lot of questions to be answered, and also about the sex chromosomes and sex hormones that can differentially affect the genetic networks, and how they can influence not only blood pressure and also susceptibility to cardiovascular disease. So I think we have a lot of work to do to explore in this area. Thank you for your attention. Yeah, thank you.